It's the 25th of October, 2024. This is the RheumNow podcast. Hi, I'm Dr. Jack Cush, executive editor of RheumNow.com. This week, we have a lot of interesting information. We're going to end with a case from the call-in audience. Ask Cush anything. But let's get into our report for this week. I found a study of nail fold capillaroscopy in patients with Behcet's. I didn't know, I'm not surprised, Behcet's being a microvascular disease, I didn't know that there would be much in the way of nail fold changes. I kind of equate nail fold changes in those patients who have sort of periungual hyperemia and desquamation, the sort of ratty changes you see in patients with lupus and dermatomyositis. But this is a study of 65 patients with Behcet's syndrome who underwent nail fold video capillaroscopy by a group that knows what they're doing. And they found that, depending on how they measured it, that about 45% of patients had vascular abnormalities on nail fold studies. They found a lot of the same things that you would find in dermatomyositis and lupus: enlarged, tortuous, giant blood vessels, microhemorrhages. They had like 5 or 6 different abnormalities, none of which sounded truly specific, but sounded like what we do see in other disorders, other autoimmune disorders. And they said that if you had 2 or more of these these nail fold video capillaroscopic abnormalities, you had a significantly increased risk of a vascular event. And there were really only 2, either venous thromboembolic events or superficial thrombophlebitis. There was no association with nail fold changes and either Raynaud's or ANA positivity or other features of Behcet's. So good to know who might be at risk for those, those dangerous things, VTE and whatnot. But maybe I'll start doing this. It's not something I have been doing previously. Saw an interesting study this week about the relapse rates in patients with idiopathic inflammatory myositis. A single center study, 105 patients, saw that 62% had evidence of relapse over time. And the question is, what was predictive? ANA positivity was somewhat predictive, but not as strong as a positive muscle biopsy with histologic findings compatible with dermato or polymyositis. And protective was the use of immunosuppressives before the relapse. Well, if it's protective, you didn't get a relapse. But again, it seemed to reduce the rate by 50%. And again, a positive biopsy increased the odds of relapse by 69%. These are, I think, worth noting. Another vasculitis study came out this week, which I don't know if you would have guessed the results, but let me ask you. Patients with giant cell arteritis, we all use high-dose corticosteroids. Have you ever used pulse steroids? Have you ever been tempted to use pulse steroids? And what do you think would be the difference between high-dose oral and pulse IV methylprednisolone, a gram times 3 days, or whatever the regimen you like? Again, this is a study of 419 patients, a retrospective analysis, which in itself, therefore, has an inherent bias. Like, why were they doing pulse steroids and whatnot? And the question is, was one superior or were they non-inferior? Of the patients that they did do, that were in this study, over 95% of them had visual symptoms at the onset. A quarter of them were treated, 26%, with IV methylprednisolone, and it was not superior to oral high-dose corticosteroids with regard to either survival or what subsequently happened to their visual acuity. So, again, no good reason to use it. Wait, there's more. Those who got treated with IV pulse steroids had more diabetes 1 year after the diagnosis of GCA. So that's the reason. I've never used it, and I don't think I would use it based on this report. Again, I'm looking for a good reason to do things. I like the data on preclinical RA, clinically suspect arthralgias, at-risk RA. I started talking about this a few years ago with the Prairie study. And you may remember the Prairie study. I'm going to talk about it again because now we have a 2-year follow-up of that study. The Prairie study was a single cohort open label treatment with 1 gram of rituximab given to or placebo to patients who had clinically suspect arthralgia. And it was 78 patients. So half got rituximab, just 1,000 IV, one-time infusion, and then they followed them. Again, at 1 year, it was somewhat beneficial. The real benefit was for about, 12 months where the lines separated as to who was going to get RA or not. A lot of people thought this was maybe a delay in RA onset. Some people said it was a negative trial. Arguable. But then again, it was suboptimal treatment with rituximab. Well, the question is, what happened to those people 2 years later? And 2 years later, there's no difference between the groups. And there certainly was no benefit either as far as the development of RA or as far as quality of life measures, patient-reported outcomes. So the Prairie study inhibiting B cells in at-risk individuals, there's not a lot of movement for that. And even though I think there was some partial benefit here, I don't know if this is ever going to be repeated again. But it adds to our body of knowledge that on the many things that don't seem to work or don't seem to have a sustained effect in treating patients who may be at risk. There was a report this week which got a lot of press. I don't know that I'm wild about it. It basically said that when you looked at patients, this was a retrospective study in patients in Sweden, and they looked at patients who were started on JAK inhibitors versus those on TNF inhibitors. And the bottom line is, while the patients did equally well, maybe there was an edge in pain relief in patients who were treated with JAKs, but it's a modest benefit. And when it comes to that that residual pain kind of stuff that happens when you control disease, you achieve an ACR20 or you achieve a DAS remission, the patient's doing very well, but yet they still have pain. The question is it inflammatory activity, non-inflammatory activity? Is it help define, difficult to treat RA? Again, these are things we've discussed in the podcast past. So I don't think that's a major addition to our knowledge base on this, but it did get a lot of press this past week. An outcome study looked at what happens in lupus in pregnancy and adverse pregnancy outcomes. This is a large meta-analysis of adverse pregnancy outcomes, and the bottom line on this was it tended to be higher in patients who had nephritis, chronic hypertension, lupus activity before and at conception, and patients with the antiphospholipid syndrome. These are the high-risk patients when it comes to pregnancy. I don't think there's any surprise there, but there's big data, big numbers in a meta-analysis that support this. I like this other study that came out of, I want to say this was out of China. This was a biomarker study in patients, lupus patients who are receiving low-dose IL-2 treatment. And again, the preliminary reports on that was that it was effective. The real question in this is, maybe, since they were doing a lot of clinical assessments and also a lot of biologic assessments, trying to look for maybe a biomarker, they wanted to see in the sub-study of 342 patients who received low-dose IL-2 or placebo. They found in that study 40% of the patients that received the IL-2 treatment were responders. And the biomarker sub-study showed predictors of responders were an SRI-4 response was predicted by rash, lupus rash, proteinuria, urinary RBCs and urinary casts, and the percentage change in CD4 positive T cells and C3 levels. When you combine those into some kind of combined score, you could have predicted an SRI-4 response with an AUC of 93%. That's really quite good. What they did show in this study is that renal markers did not correlate with clinical response as measured by any measure, including the LL-DAS measure. So it is possible. Again, this is the big issue with me and biologic therapy. We got lots of biologic therapies, and they're all unique in what they do and how they work and whatnot. But honestly, why would I use it over anything new if I'm not going to be able to predict the response?
So my word to manufacturers is give me a biomarker that gives me more than the expected response, more than a 50-50 coin flip. Or if it's an ACR, if it's an RA study, a 60-40-20 ACR 20-50-70 response. You have to do better than that. And again, having a biomarker, I mean, it's highly targeted biologic therapies. We have to get there. That's really the future. An interesting study from New York and Virginia Pasquale's group looking at mitochondrial DNA. This is mitochondrial DNA has been promulgated as a player in the pathogenesis of lupus. And in her studies, what they did was they looked at opsonized RBCs that contained mitochondria and was taken up by macrophages. And they showed that those macrophages were then potent at producing interferon, and the interferon gamma and alpha, I believe, was actually then important in activating the inflammasome to produce more IL-1 beta. So again, a lot of mechanisms where alpha interferon obviously takes over and stimulates many different cell types to promote lupus activity. In this study, it's also gamma interferon coming from macrophages that were stimulated by mitochondrial DNA. And that's sort of connecting the loop there. I think an important advance in our understanding of the pathogenesis of lupus. Looking for information about biosimilars this week, I saw a report on U.S. healthcare expenditures grew from $4.1 trillion in 2020. 2 years later, it's up $4.5 trillion. That's a 17% increase in just 2 years. Yeah, we're out of control in our spending. But they did say that in the United States, we did save over $400 billion in 2022 by the use of generic drugs and biosimilar drugs. You can imagine biosimilars are making up a big chunk of that, being that they're a lot more expensive than most of the generics that are out there. So I like that data. There is more use of biosimilars that will save the economy here and in really all countries where it's being used. Another interesting piece on biosimilars came from a study about persistence and adherence to drugs in patients with psoriatic arthritis. The point being, on the 685 PSA patient, they looked at 685 patients who were started on either a biologic or targeted synthetic between 2018-2019. They showed that persistence wasn't good. It was only 49% in a year. In a year, we said that PSA patients, for some reason, don't stay on drugs. And that's really kind of disheartening, and why there's a lot of cycling early on when these patients who are sick enough to get either a JAK inhibitor or a biologic, they are on many within a 5-year period. Interestingly, they did show that when patients were started on adalimumab, persistence rates and adherence rates were the same, whether it was the originator, adalimumab, or the biosimilar of adalimumab. And in the case of etanercept, let me get this right, the originator had actually lower adherence than did the biosimilar, which had higher adherence. Data in favor of the use of biosimilars is what I'm getting around to. Scleroderma, we worry about. The systemic sclerosis and its overlap with other conditions is also worrisome. A study of 141 patients with overlap associated with scleroderma found the most common autoantibodies that were seen were Rho52 antibodies, and then that you would expect anti-centromere and anti-SCL70s. SCL70 in the subgroup was associated with more ILD and more renal crisis. Centromeric antibodies was protective against the development of ILD. And then lastly, as you might expect, having either renal crisis or pulmonary hypertension, which was pulmonary hypertension not being associated here with anything, but renal crisis and pulmonary hypertension was associated with increased mortality in these patients. I saw a patient this week with a ganglion, looked up a lot of things about it. How do they respond? What happens and whatnot? Again, ganglion cysts tend to occur over the extensor surfaces of joints. I see them over wrists more commonly than any other place. They are thin-walled. They contain a mucinous, viscous, it's almost gel-like substance. Again, they're found adjacent to joint capsules, but they do not communicate with joint capsules. They tend to arise with repetitive strain or overuse syndromes, trauma, or in the setting of inflammatory arthritis. While you can aspirate them, and that may work, studies have shown that actually peri-cyst injections with corticosteroids don't change the outcomes. I've injected a few of these, and I'm not sure I can convince myself that I did a lot of good, although I do have a magical needle and magical skills in this regard because I am a rheumatologist. But nonetheless, the data doesn't look so good for steroid injection of ganglion cysts. I did put up this week a full read review of ILD and autoimmune disease, and the point that's taken from this, it was in the American Journal of Managed Care. I like the data that was presented, but I like that these people that you think who are with autoimmune disease, who are at risk for ILD or have any signs of it, that your imaging should be high-res CT, and that is also how they may need to be monitored. If they do develop ILD, monitoring is largely done with PFTs, and this paper did strongly recommend a multidisciplinary approach that would include the use of immunosuppressives and antifibrotics. I think we're good at one. We may not be good at antifibrotics, and we may not be good at co-managing these with pulmonary. I think it's probably something we should be considering. Some PSA and spondy kind of data. I learned from Georg Schett about 10 years ago about his work showing that people who do manual labor jobs have a higher risk of developing PSA. In a cohort study that from this week, 564 patients that blue-collar workers were much more likely to be in evidence at baseline compared to white-collar workers, 84% versus 20%, 28%, suggesting again that blue-collar and manual labor may be a risk factor for developing disease. However, occupation, blue-collar versus white-collar, had no influence on disease activity, as measured by -28 CRP and as measured a year later. So I think that's important to note, meaning that if they are a blue-collar worker and they have PSA, should they stop their job? I don't think there's a lot of great data to suggest that. That's certainly not suggested by this mostly retrospective analysis. A Turkish retrospective analysis of only 30 patients with either PSA or SPA looked at what happens if they went on secukinumab, but they had a prior exposure, a prior malignancy, and then they were exposed to secukinumab. So this was a cohort study of patients collected between over a 6-year period. They followed them for almost 3 years. Retention rate on secukinumab was high, 90% at 12 months, 81% at 24 months. Only one of the 38 patients had a local tumor recurrence, and that was a bladder cancer recurrence. The feeling being in this small cohort analysis that it is going to be safe to use a biologic with a prior malignancy. And I want to reiterate, again, ACR guidelines on RA, which has studied this much better, says that if you have a solid tumor like bladder cancer, it shouldn't influence whether you take a biologic or not. Here's someone, and I would say the same holds true in my thinking for the spondyloarthropathies. Lastly, a study of pregnancy in almost 400 patients with ankylosing spondylitis. I think the patients were started in the study at 2004, and they studied up until 2015, like almost 10 years. At the pregnancy rate in the beginning of the study was 3.8 per 100,000. It rose significantly to 8 cases per 100,000 after this 10-year period, and that's after a lot of these biologics are have been approved. So the question is, are we? And again, they didn't really talk much about biologics. That wasn't the point. I just wonder if these patients are better controlled because of the biologic era that maybe they're more apt to get pregnant. Anyway, they found that pregnancy was a little more likely if the patient was older, white, had higher incomes. When they compared AS patients who were pregnant to, like, I don't know, 9 million people who didn't have AS, I'm not sure I like that comparison. It should have been a little bit better matched, if you will. Nonetheless, the AS patients had more pregnancies, more C-sections, more gestational diabetes, and then they had a few more of the rare events, placenta previa, neonatal, small for gestational age, intrauterine fatalities. There was no difference when it came to eclampsia, preeclampsia, nor malformations. And again, I want to reinforce that these other events, like the fatalities and whatnot, there are very few events, but it was higher in percentage-wise in the AS patients than those who did not have AS. So in our last bit here, I want you to listen to Dr. Shams, who's got a case of Still's disease and elevated LFTs. Dr. Shams.
Hello, I am Dr. Shams, a rheumatologist from Lahore, Pakistan. I want to ask about a patient of adult onset Still disease who has deranged LFTs at presentation. We have started this patient on steroids, and I want to know about recommendation or guidance regarding start of methotrexate or tocilizumab in this case, in which LFTs are deranged due to the active disease. How long should we wait for this patient to have normalized liver function test before starting methotrexate or tocilizumab? Or we can start these medications while the LFTs are more than 2 to 3 times the upper limit of the normal. Thank you.
Okay, thank you, Dr. Shams. So again, to reiterate, Still's disease, didn't say what age. Patient has elevated LFTs, didn't say how high. He did say at the end, when the LFTs are 2 to 3 times the upper limit of normal, that would be 40 times 3 up to 120 AST, ALT. I'm assuming. Again, the numbers, about 2/3 of patients will have elevated LFTs with the diagnosis of Still's disease. That's true in both kids and adults. And that can complicate when they're elevated, a little bit doesn't complicate therapy, but when they're 100, 200, 300, makes you nervous, right? Are you going to use a nonsteroidal? Are you going to use prednisolone over prednisone, thinking that prednisolone is safer? And I don't do that, but a lot of people do. Are you going to use methotrexate or other drugs, including, as he mentioned, tocilizumab as the other drug he wanted to use, which may also have LFTs? For me, this is a simple story. Elevated LFTs do not prevent me from using any therapy in Still's disease, meaning I'll use methotrexate and steroids and tocilizumab and a JAK inhibitor if I need to, because you need to control swiftly, right away, in high doses, control inflammation as aggressively as possible, and you'll see those LFTs come down. The best way, of course, is with high-dose steroids, right? But I would not worry about using high-dose steroids or tocilizumab, as he asked specifically on this. If you were 10 times elevated and you're seeing LFTs of 2 to 400, you may want to wait a week or two, use the high-dose steroids, go ahead and use the IL-1 or IL-6 inhibitor, because very, very high doses, very, very high levels of LFTs could be the earliest signs of macrophage activation syndrome, in which case high-dose steroids and an IL-1 or IL-6 inhibitor would be indicated, and you would hold off on methotrexate. So again, really high, more than several hundred, going closer to, again, 300, 400, 1,000, I worry about macrophage activation syndrome. But again, I would not hold off very long, because you got to control the inflammation, and it is generalized inflammation that's driving those LFTs and this inflammatory non-infectious hepatitis that is part and parcel of the Still's disease presentation. Hope you found this useful. Make sure you check out RheumNow.live. That's the website where you can register for RheumNow.live, February 8th and 9th in Dallas, Texas. We already got, 60, 70 people registered. You can do it from home online, or you can come to Dallas where we're going to have a really good time. I'm going to drop a hint on you. We're going to have a great reception on Saturday night, followed by the Gong Show and karaoke. Yeah, you got to see it to believe it. See you in Dallas.